Okay, good evening everyone. Welcome to this very important webinar. So tonight we have the opportunity to discuss daily basis issue on cardiac surgery, which is myocardial protection. So this webinar is promoted by the Brazilian Society of Cardiovascular Surgery in cooperation with Contact Medical. So we have two distinguished speakers tonight. First one will be William Nicotra. He's a clinical perfusionist and medical science liaison for Custodial United States from Pittsburgh. So please, thank you so much for joining us tonight, and we're going to start it.
All right, well, thank you for inviting me. Thank you, Contati Medical, for the invitation. It's a pleasure to speak with you. Again, I am Bill Nicotra. I've been a practicing perfusionist for 33 years in the United States, and I have 10 plus years experience with custodial HTK. So I'm here to share my experience as a perfusionist and talk to you today about custodial. So no disclosures other than I work for Essential Pharmaceuticals as their medical science liaison, as you already heard. So tonight I'm just going to talk about custodial origin just briefly, take a look at the components that make up custodial HTK, and I'm going to share with you our delivery protocol, and then take a look at some clinical applications this evening. So as you're aware of, Dr. Hans Breschneider developed this formulary in the early 1970s along with Professor Preuss, and they believed that protecting the heart was equally as important as stopping the heart. So they came up with histidine, as you can see here in the original manuscript. That was the key component. So we're going to look at custodial HTK and start with just its mechanism of action. You're all aware that this is an intracellular solution, very low sodium, very low calcium. It leads to a decrease in the oxygen consumption during the arrested heart, and there's no other method that can achieve such a decrease of consumption. When you look at the components of HTK, here they are listed in millimoles. In the United States, we like to utilize milliequivalents. So if you are using milliequivalents, it's not an exact science, but roughly cut these numbers in half. So we've got 7 milliequivalents of sodium in the solution, only 5 milliequivalents of potassium, very little, and negligible amounts of calcium. So that's the top half. I consider the arresting components, and then the bottom half, you can see the delineation starting with the HTK, histidine, tryptophan, and ketoglutarate as the protecting components of the solution. So I consider custodial HTK a paradigm shift. It's different from everything else currently that you're using to protect the heart. And basically, the way we arrest the heart, we create that electromechanical gradient. So we're just pulling sodium from the extracellular space into the intracellular space. Thus, we reduce the amount of positive ions so that we stop the action potential right there. So the heart will stay in an akinetic state for the entirety of the procedure, as long as that there's no reperfusion or no other introduction of the positive sodium ions. So that's really basically it. The resting component is quite simple, but very effective. But here's where I think custodial HTK separates itself from other myocardial protection strategies out there. And let's start with histidine, which I think is the secret sauce of the solution. You may well know that histidine is an alpha amino acid with a imidazole functional group, and it basically protects inflamed tissues, and it also is a great scavenger reaction to oxygen free radicals and those that are generated by the acute inflammatory response. And obviously that's what's happening when we put the cross clamp on and we stop perfusion throughout the myocardium. We are creating that inflammatory response. And histidine also inhibits cytokine and growth factors long term. So it is, responsible for the avoidance of the reperfusion injury, and that's often been an issue with myocardial preservation for years, as you may well know. Here's a fine example on this chart here of how custodial actually is beneficial in protecting the heart. And if you can appreciate the top line here with the X's, that we're going to refer to that as the Brettschneider's or the custodial line. And then second from the bottom is your typical Brettschneider's, your typical St. Thomas solution. So when you're looking at cross-clamp times at 0 minutes, you can see that roughly the pH is exactly the same for all. We're all starting right around 7.40. But as soon as you start breaking out about 10 to 15 minutes, immediately you start seeing in the St. Thomas group, that pH is dropping down to 7.1 after just 15 minutes. And at 60 minutes, that pH is well below 7 now. And if you look at the top line with the custodial, at 60 minutes, you're still at a pH of 7.3. So this really does a great job of showing the buffering capacity of histidine as it relates to stabilizing the pH in that anaerobic environment. And if you go out to the 120 minutes of ischemic time, you can see we're just starting to dip below the pH of 7.0. We're roughly around 6.8. And if you look at the St. Thomas bar graph, then you're well below 6.5. So you're in the 6.3 pH. So obviously, you need to redose with St. Thomas solutions at the 20 to 30 minute mark. And then with the custodial group, redosing is often only necessary right there at the 120 minute mark. This graph also does a great job of showing you that, as myocardial lactates increase, the top line is the custodial HTK, you can see that the pH is being stabilized significantly over the second to last bar graph, which is the St. Thomas solution. The pH drops significantly. And these are ATP stores that are preserved during a transplantation. So also the red line is HTK, and looking at some of the other myocardial protective solutions, it does a good job of preserving the AT3 levels. So that's histidine, and then we're going to break into tryptophan. We know tryptophan is a membrane stabilizer, anchoring protein, and it's basically there to help facilitate the ion transport. So it's going to help us pull the sodium ions out of that intracellular space so that we get a nice quick arrest. And then also when the clamp is removed during reperfusion, it will transport those ions right back in. So typically, when people use HTK for the first time, they'll typically see a response to sinus rhythm a little faster than that they typically see because of that ion transportation. And then finally, the ketoglutarate. Obviously, that's the energy source. That's like giving a hot shot, if you're familiar with doing so, or you still may have that in your practice. It's going to provide that energy source for reperfusion in the post-ischemic phase. And it's also a great nitrogen scavenger, so it's going to help with that inflammatory response as well. And then mannitol. We have, as you recall in the early slide, we have a high dose of mannitol in our solution. There were 30 millimoles of mannitol in our solution. And it's purported that mannitol has its greatest effect during the beginning of an ischemic insult. And that's exactly what's happening when we put the cross clamp on. We're creating an ischemic insult. So what a better time to have such a high dose of mannitol in your solution. It's also a great oxygen-free radical scavenger. And secondarily, when it's flushed into the systemic system after delivery, it has some renal protective properties as well, which is a huge added benefit that you won't find in other myocardial protection strategies. So I want to switch gears here and talk about our delivery protocol. This is how we were doing it at Temple University, where I gained most of my clinical experience. So custodial HDK has to be stored refrigerated at 2 to 10 degrees Celsius. So that's pretty standard. And you can use any standard ratio system, and that's why I'm going to back up a little bit. That's why I put this picture in this particular slide. You really could deliver custodial HTK with a coil and bucket and some ice. I mean, you really don't have to manipulate your system and change what you're doing to use custodial. It's very adaptable to whatever system you're currently using. And then during the delivery, we will deliver it at 3 to 4 degrees centigrade, much the way you typically do currently right now. And our dose is calculated at 20 mLs, per kilo to a maximum dose of 2 liters. At Temple University, we just gave the maximum dose of 2 liters on every case. And then subsequent doses are given at the same temperature for half of whatever the loading dose was. And again, if we needed to give a second dose, we gave a 1 liter dose. So when we start delivering it, we basically want to deliver it at just enough pressure to close the aortic valve. So we find that at about 125 millimeters of mercury. Close the aortic valve, and then as soon as you see a rest, then we back off to about 80 millimeters of mercury for about 5 to 6 minutes. And the rate and the time is so much more important than the actual volume. But typically, if you do give it at this rate, you'll typically deliver the whole 2 liters in about six minutes. So that's really important, that it's not just volume, it's the actual time and rate, so that we get that nice ion transition and we make sure we get the heart adequately protected. And this is pretty common sense. This is for really all cardioplegias, but make sure your heart's not distended so that you get really nice even distribution of the custodial during delivery. So again, as you saw earlier in the slide, and as what our protocol was, between the 90 and 120 minute mark, that's when we start thinking about giving an additional dose. And typically, we'll just see where we're at in the procedure. And if we know this is going to be a concomitant case or a root repair or something that's going to take a significant amount of time, then we will go ahead and give an additional dose at the 120 minute mark. If it's something where we're typically going to be about another 15 or 20 minutes past the 2 hour mark, we let it go. We do not redose at that particular time. And then you typically will have to hemoconcentrate, do some type of Z buffing if you don't vent the custodial into a throwaway sucker or an auto transfusion system. So definitely we'll need an ultrafiltration system, because again, this is 100% crystalloid cardioplegia delivery technique. So going over some of the benefits that I saw as a clinician over my years at Temple utilizing this, the low viscosity allows you to get to the microvasculature that no other myocardial protection solution does. So it allows for rapid cooling, and it does a really great job of getting that septal temperature nice and cold. When you're delivering straight crystalloid cardioplegia for 5 or 6 minutes, you're really going to do a great job of reducing the temperature of the myocardium, and we know that's an extremely important part of myocardial protection is temperature. So also the reduced potassium levels. You saw that earlier in the slide, the level that we'd add in there. If you don't vent it, it's okay, because there are no harmful effects because there's very little potassium. So if you've got patients that have renal insufficiency or some kind of advanced kidney disease, it's not going to hit those kidneys that hard. So that's really a great benefit to have. We already talked about this superior buffering capacity when compared to blood, as you saw when St. Thomas was compared to custodial and buffering. But this one's really important to me. one recognized protocol. So for every case that we did, for every surgeon, for every perfusionist, we only did it one way. So there was no confusion, there was no guesswork, and there was no experimenting intraoperatively how much to give or at what rate. Or so that really was important to me. And then there's no additives necessary. So if you get an emergency case, you just pull it from the refrigerator, hang it, and go. It's terrific in helping you crash on bypass for any emergencies. And retrograde's often unnecessary, so it does a great job of protecting the right heart, which is usually why you'd want to give a retrograde dose. Just a quick comparison of solution components. Just a nice little chart. I'm not going to go over it. Just wanted to give you an idea of the sodium, potassium, and mannitol and other important components that separate these various solutions. So there's obviously a few challenges. Hemodilution is definitely a challenge if you don't vent the custodial in the right atrium. So you're definitely going to have to hemoconcentrate. So if you've got a quick AVR standalone, it's going to be a little more challenging to utilize a hemoconcentrator. And then hyponatremia, if you do not vent the custodial, your sodium levels are going to go down. There's no way around that, but it resolves itself naturally without intervention. But the great thing is that whether you do resolve it or don't resolve it, it really doesn't make any difference clinically. So, giving sodium bicarb, for example, isn't going to hurt the patient at all if you want to go ahead and treat that hyponatremia. And then this was just from a clinician standpoint only. The X is obviously meaning I felt that it was a benefit, and you can see those single dose. It's a no doubter that we are the absolute best for just do the single shot technique. And then viscosity, obviously we're the best there as well, but I do give Delnito those if you're using the original formulary mixed 1:4. Hemodilution, and that's if you're not using a hemoconcentrator, obviously St. Thomas has that benefit. But then, post-potassium levels, that's an obvious. And the cost, as I'm going to show in a slide later or two, that the cost can be an actual benefit with this solution if utilized properly. And then, obviously, quality control is unbeatable there because there are so many formularies, as you'll probably hear later, that how can you control what's actually being given to the patient if you can't track it and test it for quality. I just wanted to go over real quick a typical case that I had at Temple utilizing this 67-year-old female. She was small, 150 centimeters and 46 kilos. We did, the patient was status post mitral valve repair with hypertension, COPD, Hep C, and a decent EF, 40%. The patient had cold agglutins. And oh, by the way, this is a great protection strategy for a patient with cold agglutins, and we actually developed a protocol to deal with these patients. So we did a mitral valve replacement and a tricuspid valve repair. Typical cross-lamp time, 82 minutes. Obviously just one dose with 2 liters. And notice that the hemoglobin didn't change all that much, and we are hemoconcentrating, I understand, but really a small patient that's 46 kilos that we just gave 2 liters of crystalloid cardioplegia, no real change in the hemoglobin. And then there's the effect of the hyponatremia, and the glucose was totally under control. We didn't give a hot shot. Patient didn't require cardioversion, sinus rhythm, non-pace leaving the OR. Did terrific. So that's a typical result that we experienced at Temple, and that's a case that I actually pumped. I often hear people asking me, can it be used in coronary artery bypass? Because there was some concern for utilizing custodial for these cases, and there are studies out there and data that shows that it is effective as a strategy. And I think you'll recognize this one. This will be might be shared by our colleagues, but this was done in Turkey by our Dr. Gunaydin, and we're looking at 100 patients in the St. Thomas, blood cardioplegia, Delnito, and HTK. And when you look at all of them side by side, pretty similar bypass times and cross-clamp times, but you'll notice a slight improvement of VFib rates with the HTK group. And the need for inotropic support's definitely significantly better with the HTK. Need for balloon pump was better, and the need for transfusions were equal or slightly better. So it definitely shows that it can be used safely and effectively for CABG use. And this was another study by another group that had similar outcomes that said it was at least clinically equivalent to St. Thomas for use in CABG. So it can be used for that purpose. Wanted to look at cost savings. You were supposed to get a whole lecture on this. This is really only going to be one slide to address that, but I think it's you can get the point. And this is by Dr. Hummel, and this is his findings. When comparing custodial HTK to their traditional cardioplegia, blood cardioplegia methods, right here says everything you need to know, that the total charges for traditional blood cardioplegia cases worked out to be, $22,000 plus, and the custodial HTK group reduced by $3,000 per case. Obviously, you see that the pharmacy costs go up because custodial is typically slightly more expensive than what you're currently using, but you can see that you make that up significantly in other areas. And here's a study out of Wisconsin by Karachi and his group, independent study looking at similar factors. And if you notice, he came up with an identical result. He showed a cost savings of $3,500 per procedure when adding up anesthesia times, OR times, and things that, contribute to the actual cost of the case. So another study proving exactly that same point. And then I just wanted to just tap into hemodilution quickly, because that was one of the concerns that I listed earlier. And this is data from the SCOPE registry in the United States by Specialty Care. It's the largest database that the United States currently has. And when looking at all of the cardioplegia methods in their registry, 4-to-1, microplege, Delnito, and HTK, if you look at the amount of blood transfusions, slightly better, not statistically significant, but slightly better in the HTK group. Lowest hematocrit, slightly better. So you see that going on down the line, that even though it wasn't statistically different, it's not statistically worse, that as you would typically consider when you're using 100% crystalloid strategy. So that this data shows that very poignantly. So wrapping up today, custodial HTK, you often is referenced as Brecht-Schneider solution. It was developed as a cardioplegia solution, even though it has FDA designation for organ transplantation here in the United States. Obviously used worldwide in over 1,000 studies showing that its efficacy is equal or better in all facets, and millions of procedures done in both cardiac transplant and cardiac surgeries around the country. And with that, I'll stop here, and I'll be available for questions later in the talk.
Thank you very much, Bill, for this excellent presentation. Sure. So before we move on, probably we're gonna leave the questions to the end. So the audience, please use the Q&A button to address the questions to the speakers. So now I'm pass on to Dr. Eduardo, our president of the Brazilian Society of Cardiovascular Surgery, to introduce the next speaker.
Brilliant presentation, and I'd like to introduce Dr. Serdar Gunaydin. He is a cardiothoracic surgeon in Turkey. He's a professor of cardiovascular surgery at Numun Training and Research Hospital. And we'll talk about the myocardial presentation, comparing custodial and Delnito. Dr. Serdar, please.
Hello. So it's already 1:30 a.m. in the morning here, so I can say good morning to you. And it's very nice to be with my Brazilian colleagues, and it's very exciting also. And thank you very much for the Society of Brazilian Society of Cardiovascular Surgery and the Contatti Medical. So I'm working here in Ankara, the capital city of Turkey. It's one of the largest hospitals in Europe. We have more than about 4,000 beds and doing about 4,000 open heart cases a year. So when we talk about cardioplegia as a concept, and when we check for the PubMed, for example, we see that until now there are about 500,000 papers on cardiac surgery, and usually 20,000 of these papers are about cardioplegia, and most of them are about blood cardioplegia. So we are all very much accustomed to blood cardioplegia until now. But in the last 5 to 10 years, with the improvement in minimally invasive cardiac surgery, we are again facing the option of using single-dose techniques in every type of adult surgery. And we are now seeing more and more papers, especially coming from Dalnido's side. And then until now, we have about 250 papers right now about the adult use of single-dose techniques. So but most number of papers are on blood cardioplegia, but this is also an increasing side of single-dose techniques. So we are always coming to discuss the efficacy of single-dose techniques in adult cardiac surgery. So as you know, we are using cardioplegia in order to overcome the ischemia reperfusion injury. And we have many, many different types of cardioplegic formulas. And of course, one of them is single-dose techniques, but mostly the blood cardioplegia idea is to raise the resting membrane action potential over -80 and to have a refractory myocardium that's very much good for protection and also easy to operate. So we have many different additives also. Of course, we all use most of them before, and we have different papers on that. But these are always changing, and it's a kind of fashion. And now the fashion is single-dose techniques. Because Dalnido's solution has become more and more center of attraction to use in adult surgery. So this solution was basically introduced to pediatric cardiac surgery about 25 years ago. And it's a very simple solution. It's a crystalloid solution, including mannitol, magnesium, sodium bicarbonate, potassium, and especially lidocaine. Lidocaine is, you know, as a membrane stabilizer, and is the most important point in this formula. So most of the Dalnido solution is mixed with blood, 1 to 4, and it's given like about 2 liters continuously for the patients. And then in the early times for pediatric cases, the protection time was supposed to be around 2 hours, but for adult, in the beginning with the classical formula, the introduction time was about 1.5 hours. And now we are seeing papers that brings to 1 hour and let's say 50 minutes. And at last I saw 2 papers recently underlining the protection time of 40 minutes. So it's still on discussion, the way of using in adult cardiac surgery. So theoretically, this solution reduces the energy consumption, blocks the calcium flux into the cells, and promotes the anaerobic glycolysis. So these are all, you know, as you can see, the protection ideas for the pediatric patient population. So initially there was not any suggestion for the adult population, but unfortunately now, especially in the United States, it's been available for adults, let's say 8 to 10 years ago, and now we are seeing 300 different formulas in US, and they are all calling themselves Dalnido solutions, but they have completely different formulas. So we have the opportunity to discuss this technique and this discrepancy with Dr. Dalnido himself, and he's not very much comfortable about this incredible number of solutions calling themselves Dalnido. He is, of course, not supporting any of them, but with the classical formula, is the only idea is to use for pediatric patients. But now, of course, whatever he does, it's becoming more and more popular in the adult population. HTK is very well described by Bill before with the amino acid-based solution that was also introduced in 1975. So it's also a very long history to use, especially for transplantation. So when we basically compare until now, we can see that Dalnido was introduced for pediatric and HTK for pediatric transplantation, basically, and now adult surgery. So when we're talking about pediatric formula, we mean that it's very much useful in immature hearts with very low temperature, because when you're doing pediatric surgery, usually you're doing the operation about 28 or 30 degrees. But for CABG, for example, we are using 34, 32 degrees. So it's completely different. And the point is that we now have more than 300 different modifications of Dalnido, but HTK is only a single dose formula. So we have a very good satisfactory evidence in pediatric cardiac surgery for Dalnido. And we have good results in for HTK in valve surgery, in adult valve surgery, and transplantation until now. So hemodilution is another factor. We will discuss it later. So lidocaine in Dalnido is very important, because even Dalnido himself says, if you are using Dalnido, and if you are using an additional dose of Dalnido, you have to be very much careful with lidocaine, because this is a drug that can go easily to the toxic level very quickly. So we have a very limited data and very limited clinical parameters. So we don't know anything about the long-term protection of those two solutions. There are many, many papers, as I've told you before, more than 200 papers in the last 2-3 years. So basically, they all say, okay, single-dose formulas can be used in adult cardiac surgery with non-inferior results. They are not better than the conventional cardioplegic solutions like St. Thomas or blood, but they are non-inferior. Okay, if you are using them, you're only using them for your comfort, because you give on a single dose, and you, for example, for Dalnido, you can wait up to 1 hour now. They say for HTK, you can go up to 2 hours. And some other papers, there are also meta-analysis of covering many, many papers, and the results are always the same. Clinical results are not better, but non-inferior for single-dose techniques. And even when you're using an adult surgery, even in adult coronary bypass surgery, they say, okay, you can use them in low-risk coronary bypass surgery in the publications. So let me summarize the current literature. We can say that the clinical results are very much same with the conventional cardiac surgery. And for coronary artery bypass surgery, the results are supporting low-risk patients for single-dose techniques. So when we check for the availability or the choice of cardioplegic solutions all over the world, as you can see here, so St. Thomas is one of the best choice in the world. And also in Europe, the blood cardioplegia is one of the best choice until now. In US, they did a very good survey of about 16,000 patients. And for CABG, the best choice solution was 4-to-1 blood cardioplegia. But for valve surgery, especially minimally invasive valve surgery, single-dose techniques were very much favorable ones. But for urgent surgery, HTK was the most choice, the best choice, because when it's very much urgent, you don't think to prepare any solutions. You have to take just only one, which is always available. So that's all about the current literature, and now what we are going to say according to our own research. So the first question was, which single-dose technique for which patients, especially for CABG? So we did an experimental study to understand which cells are those formulas that are effective. So we just chose 3 different cell lines. The first cell line was for pediatric heart. The second cell line was the adult cell line for the adult heart. And the other one was the fiber skeleton of the heart. So we have 3 different parts of the heart, and we will contact them with different cardioplegic solutions. So we put the cell lines here in the valves, and we put St. Thomas, blood, HTK, and Dalnido, and we just follow up them for the baseline, for 100 minutes, 2 hours, 3 hours, and up to 48 hours. And we check for the viability and the support of those cardioplegic solutions. So idea was to test with the MTT test. This is a cell viability test to understand the long-term protection. So we did microscopic staining to understand early apoptosis, that means stunning myocardium, or infarction or necrosis, or we did an LDH test to understand the toxicity. For example, I told you lidocaine may be toxic in the long term. So here are the results. When you talk about the structure of the heart, the fibromyoblast, HTK was significantly better in the long term with respect to other solutions. For adult cells, again, the HTK was much better than the other solutions in the long term. And for neonatal cell, for the pediatric cell, HTK and Dalnido solution were effective in the long term, 24 hours, 48 hours in the protection. So when, of course, the figure will be very much impressive for us. So if you see the structure of the heart, this is the HTK. When you see the green cells, that means they are viable. When you see the red cells, that means they are not viable. So this is the adult cells. You see this is the control group. The HTK group in the long term are very much better, as you see very green. Dalnido here in the long term, not very much supportive. So blood is also not bad in the long term. So we also count all those cells to understand the efficacy of the single dose techniques in the long term. And for the toxicity, lidocaine dose didn't have any toxicity in the long term in the Dalnido solution. So as a conclusion of this first study, we can say that we concluded that on the cell lines, single dose techniques are effective in the long term, like the blood cardioplegia. And especially in the adult cell, HTK is very much effective. For pediatric cells, HTK and Dalnido were both effective solutions. And then the second question, how about the long-term protection in the clinical setting? Because we don't have, as I've told you, very much data for those patients in the long term. So at this time, we have 3 different groups with 100 patients in each group. And in that groups, we did full monitorization up to 1 month after the operation. So this is how we did. This is the patient. We put like an iPad device on those patients. This is a full monitorization, or 24/7 monitorization. And we have a call center like this. So these patients also have a button. When they feel something wrong, they press the button, and this call center contacts with them and learn their symptoms, like their angina or shortness of breath or whatever. So we also have the monitorization continuously, that we have the reports like this. So we have a very detailed analysis of the QT intervals, ST segmental analysis, heart blocks, atrial fibrillation, bradycardia, anything. So we follow up those patients, 100 patients from each group, up to 1 month to understand the long-term protection of these cardioplegic solutions. So in the early postoperative period, as we expected, there is not any clinical difference. So when we are talking about in-hospital, like 7-day protection, it's very difficult to show any difference in between conventional or single-dose techniques. Only we just demonstrated that interleukin levels were significantly higher in the Dalnido group in the early postoperative period. So this may give an idea of the early inflammatory response that may end up something significant in the long term. And this is what we did, on the CABG patients. So these are the clinical outcomes. As you see, rehospitalization rate for 50 patients in each group was very high in the Dalnido group in the first month. Also, total events like the bradycardia, tachycardia, whatever, the event rate was significantly higher in the Dalnido group. But atrial fibrillation rate was significantly higher in the Dalnido group with respect to other groups. This is the graph. As you see, tachycardia was much more frequent in the first month postoperative period for Dalnido. And atrial fibrillation rate was significantly higher with respect to all other cardioplegic solutions. So in the long term, Dalnido has some problems, especially for the arrhythmic outcomes. So as a conclusion, this is one of the first a study showing long-term protection of these cardioplegic solutions, then we can say dalnido is safe in the early postoperative period, but in the long term, it may come up with rehospitalization or arrhythmia incidents that may end up, of course, from the cost analysis that may have a great impact. And how about the third question, hemodilution? Does this single dose techniques cause hemodilution? Because you give 2 liters of blood in, let's say, 5 to 10 minutes, and this theoretically should cause hemodilution. So we checked for this. Again, we compared 4 different groups. So about more than 200 patients in each groups. And the endpoint was the transfusion and hematocrit change. But in our clinical practice, when we are giving the single dose techniques to CABG patients, we always use retrograde cannula because of the equal distribution of this cardioplegia all over the heart. And then second factor, we are always using venting or ultrafiltration at the end of the operation. This is our routine. So this is the delivered volume of each cardioplegic solution. And of course, we did ultrafiltration until 25% hematocrit at the end of cardiopulmonary bypass. And in the early postoperative period, again, there was not any statistically significant difference as we expected. And this is the hematocrit levels, baseline, on pump, last dose, after ultrafiltration, ICM before discharge. As you see, there is not any clinical significant difference in any of those cardioplegic groups if you use ultrafiltration at the end of the cardiopulmonary bypass. And how about the another question, redosing? Because when we are talking about dalnido, as I've told you, we begin with the conventional formula that dalnido described, and now we have more than 300 different formulas. But the idea was to protect the heart for 1.5 hours in the beginning. After the first papers, they said 1.5 hours is too long. We should redose it in every hour. And I've told you now some papers to suggest redosing in every 40 minutes. So redosing is a kind of must for dalnido because for HTK or castidiol, we had data to support for 2 hours. But in our clinical practice, we always redose for HTK for 1.5 hours. But for dalnido, I now suggest 60 minutes. But how about the outcomes? So we compared 2 groups again with dalnido and HTK. So in these 2 groups, when we had a redosing, we did 2 subgroups for each group. So we have 4 groups, dalnido HTK with a single dose, dalnido HTK with an additional redosing. And we compared the aquaporins. Aquaporin is a protein in the cell that controls the water handling of the cell. So when the cell is attacked by the overvolume, cell just start to synthesize aquaporin to deal with this overvolume. So when you have enough aquaporin, that means you are handling the water content very well. So we check for the aquaporin levels. Again, in the early postoperative period, these are the first 2 single dose groups. There is not any significant difference in the early postoperative period for CABG patients. And this is the redosing group. This is 30 patients in each group for redosing. So in the redosing group of dalnido, we see more frequent atrial fibrillation in the postoperative period and AV blocks in the postoperative period. So that makes the ICU stay longer. So redosing is not innocent because you are changing the chemistry of the cell. So you may have, again, very much arrhythmia in the postoperative period. Also, interleukin levels are very much disturbed if you give redosing. So this is the redosing of the dalnido. And then especially syndekine levels, this is also cell protection, cell membrane protection is significantly worse in the dalnido redosing group. So this is also the microscopic picture. Here I show you the aquaporin levels. So this is the dalnido single dose and the additional dose. You see the cellular edema in the microscopy. And the HTK and the HTK redosing group, it looks much better than the other one. So redosing is not innocent. Of course, you can redose it every 60 minutes or every 40 minutes, but you will change all the chemistry of the cell and make the very much a dangerous impact in the clinical outcome. So just try to wrap up what we are presenting. So when we're dealing with the single dose, we need to be very much careful about some very important details. So temperature and pressure is very important when you're giving single dose, because, for example, Dalnido doesn't keep the heart cold. So you have to arrange this temperature, always just keep on being alert on the temperature of the heart. So duration of infusion is important. For example, as also Bill pointed out, for HDK, you should at least give the solution in 5 to 7 minutes. It's a long time before the operation, but it's important because you will get the ionic levels at the end of the 5 minutes or 6 minutes. So this is important. For CABG, we always use retrograde cannula for the even distribution of the cardioplegic technique to all over the heart. We always do LA venting or some venting to take the first impact of 2 liters out of the heart, because this is also important for the sodium imbalance for HDK. We never have any sodium imbalance if you're doing venting. If we are not venting, we need to do ultrafiltration to just take the excessive volume out and to overcome the hemodilution. If we need a redosing for Dalnido, we always lower the dose of lidocaine into half. So this is also very important because we have seen many lidocaine toxicity if we redose the same formula in the second time. For Dalnido, of course, we still have very much important points to discuss. There are 300 different formulations, all calls themselves Dalnido. We are not still certain about the safe duration. Is it 40 minutes, 60 minutes, 1 hour, or what? And of course, redosing time and redosing impact, as I've told you, is very important because you'll change the chemistry of the cell, and there are some expected complications in the redosing period. So what do I do? In my clinical practice, of course, I also depend on the hospital policy, and I want to use custodial for all my patients, but it's not, of course, affordable to even in our hospital current practice. So for a simple case with a good left ventricular function and an expected cross-clamp time lower than 1 hour, or where simple case, poor left ventricular function or cross-clamp time expected to be lower than 1 hour, I always use blood cardioplagia. For combined cases with good left ventricular function and cross-clamp time over 1 hour, but below 1.5 hours, so it should be around 60 to 70 minutes, I can use Dalnido solution. But for combined cases with poor ventricular function and cross-clamp time over 1.5 hours, for emergency cases or for minimally invasive surgery, we always do, especially valves for all minimally invasive surgery, I always want to use custodial in those patient groups. So we are also doing some more, because we are also doing heart transplantation in our clinic, like 25 to 30 heart transplants a year. So we are now started to do another study to compare the heart transplant storage solutions. Of course, you know, custodial is also one of them, like the University of Wisconsin solution or Celsior. So in the early phase, again, we use some cell culture techniques, and we have also very good results for custodial here. Celsior is also good. UV is here, and the control group. So we will report those outcomes later in very brief. So thank you very much for this time, and we are ready for the questions. Thank you.
Nice presentation. Thank you, Brilliant. And I have a question for you, Professor. It's not easy to calculate how much money cost an innovation as custodial for our ancient routine. How can I calculate this? Because I suppose if you look just for numbers, custodial is much expensive than the ancient cardioplegias. But during the I suppose the hospital stay will be much shorter if you use the custodial. How can I do this account? How can I do this bill at the end of the hospitalization?
Thank you very much. And so especially we now started the evaluation for, especially from the cost perspective. We are using our data for 1 month follow-up. So as I presented before, in the 1 month follow-up for all those groups, for example, some groups have more rehospitalization rate or more incidence of atrial fibrillation. So these all need some kind of treatment. So if you rehospitalize the patients, this is an additional cost. Or if patient has an atrial fibrillation that needs the treatment, you give medical treatment or whatever, you hospitalize the patient, you do something else. So these are all some additional costs. So we are now, for the short term, it's impossible to find any cost difference for those patients. In 1 week or whatever, for example, for cabbage, routine case, we hospitalize them up to 5 days, 6 days, let's say, and there's no difference. But maybe in 1 month period, we can find some cost differences or cost efficiency.
Bill, what do you think about that?
That's a great question. And I can relate some experiences here in the United States. Histidine is an expensive drug. It just is, and it is what separates custodial from the other groups. So typically that's why you'll see that augmented upfront cost. But at Temple University, we routinely had lower post-op AFib rates, lower than the STS national reported data. So we would see improved outcomes and translate those outcomes just like Dr. Hummel did, as well as the Karachi team. And I've spoken to both of them personally, and I wish we had done a similar study at Temple, but I can certainly tell you the outcome data. We did have lower post-op AFib rates, and we know that's in a very cost, that bears a lot of cost burden on an institution.
I have a question here from the audience. I think both speakers can answer that. How often do you redose custodial and del nido? I work in 2 hospitals. In one hospital, we use custodial and redose it in 3 hours. The other one, we use del nido and redose in 1 hour and a half.
From my perspective, for custodial, 1.5 hours is very, very well safe. For del nido, I always do redosing at 1 hour. I cannot wait for 1.5 hours because I don't have very good results in the 1.5 hour group.
I will piggyback what Dr. Gunaydin just said with the fact that with the original del nido formulary, if that's what you're utilizing as your strategy, only 25% of your total concentration is blood, which is the buffering capacity. So if you do not redose within that 1 hour, you lose the function of the buffering capacity of blood, and obviously the myocardium is going to warm up. So I totally agree with Dr. Gunaydin in that if you're using the original formulary, you definitely need to redose within an hour because you only have 25% of the total solution to protect the heart.
I have myself a question to you too regarding coronary artery disease. In case of severe and diffuse coronary artery disease, would you consider to split your single shot antegrade and retrogradely? First, because Bill said that retrograde is not used very often, but Serdar said that he likes to use retrograde. So considering custodial, for example, would you consider to split this single dose via antegradally and retrogradely?
Especially for a high-risk patient with a cabbage, I strongly advise to use retrograde cannulation and split the dose.
Yeah, and our typical clinical experience with those particular patients, we often did not arrest at all. We would just do assisted beating heart surgery with those. So typically we didn't utilize the cardioplegia strategy for those patients. So I'd have to defer.
We have a question here, and the person said, the table presented by Nicotra has a direct comparison course between custodial and blood cardioplegia. Could you go over this comparison again, please?
Sure, I'll have to share my screen here. I'm looking at the buffering capacity. I'm certain that's what we're looking at. So that's probably the slide that the question is definitely coming from. And if you can see my pointer here, this was the custodial line here, this top line, looking at the pH as it relates to the ischemic time down here below. And this was the St. Thomas group blood cardioplegia right there. And that demonstrates exactly what I was talking about with the buffering capacity of custodial with the high histidine. If you look at St. Thomas, which is a typical 4-to-1 blood cardioplegia strategy, that's 75% of that solution has the buffering capacity of blood. If you're using original Del Nido formulary and the temperature of the myocardium is going to rise over time, it's fair to say, and this study was done before Del Nido became as popular as it is, but it's fair to conclude that it could be even lower than the St. Thomas if we were to redo this study all over again. So just looking at the buffering capacity only and not the effectiveness of the arrest, it's fair to say that comparing to Del Nido that you should be looking at similar results to the St. Thomas solution. I hope that was helpful.
Thank you. We have a comment here from Patricia Oliveira. She's congratulating the speakers, and she says she's wondering about the hyperfusion period when using custodial. So she says that she learned in Gießen, Germany, according to the manufacturer recommendation, that we should have a hyperfusion time of 1/3 of the cross-clamp time before going off pump. So could you please address that?
I can relate just my experience at Temple and other institutions that I've had the privilege of observing. And like I mentioned earlier with the tryptophan, we're seeing a fast response to sinus rhythm. And so typically our reperfusion times actually tend to be shorter than the recommended manufacturer's protocol. So my experience clinically is that typically they're a little shorter, in fact. And I'll defer to Dr. Gunaydin as well.
Dr. Serdar, do you do any reperfusion for such a long time?
And so very rarely, because I'm usually waiting up to 2 hours for custodial in my cases. If there's no electrical activity, for myself, 2 hours is safe enough. So after 2 hours, but whatever the situation, I give the redosing if I'm going over 2 hours.
What about the temperature? In the hypertrophic patients, what do you think about that? There's something that you have to do different?
It's very important because I wish we could measure the core temperature of the heart during our studies, but it was not very much feasible to have a very correct temperature of the heart. So especially when we are using Del Nido, temperature is very important. So we always do topical cooling and every means of cooling. We are very much careful about, especially to keep the heart as cool as possible. So, but of course, it's not a scientific explanation because we don't have any quantitative data that we don't measure the temperature of the heart.
So we have another question and comment and question here from Albin Marath. Dr. Albin is from London. He says that some concern about the presentation for not mention the cold environment, slush temperature, Rob's experiment with bowl of saline, surface protection, pre and post-op troponin levels, volume of cardioplegia in relation to emergence of post-op ejection fraction, priming of the heart with propranolol, need for ultrafiltration and cardiac hypertrophy as addressed here. And he's concerned that this aspect should be factored into his studies.
Sure, but in our studies, as you can see from the titles, the CABG patients are all high-risk patients because this is also linked to the literature, because in the literature for single dose techniques, only low risk patients for CABG surgery was suggested. But in our studies, we always do a study with the very high STS scores for CABG patients. So we really studied high risk patients. So we had a good data on high risk patients. For temperature, as I've told you, we don't have any quantitative results. We cannot measure the temperature of the heart, but we are very much careful about, especially for the introduction of the cardioplegia with the very well-known temperature. We are always checking the temperature and pressure when we are giving the cardioplegia, and also the duration of the infusion. They are all very important as far as we believe. So for the troponin enzyme levels, we always presented in every study the troponin enzyme levels, but we go further and we documented the interleukin levels plus the glycocalyx levels and plus the aquaporin levels. They are much more sensitive than the troponin levels. So when we present troponin levels, we usually cannot show any significant differences. But for glycocalyx protection, that's the membrane protection of the cell, this very, very sensitive measurement. We really demonstrated very clinical differences in between those cardioplegic techniques. So for myocardial, let's say hypertrophy, of course, we also have the minimally invasive cardiac surgery results that I didn't mention them here, but we always also worked with the group with minimally invasive valve surgery with low ejection fraction.
We have a question here from Juan Mejia. He is a surgeon made a lot of transplants here in northeast of Brazil. He asks, would you recommend a hot shot dose before releasing the cross-clamping in the procedures with custodial?
No, I don't, because in the formula, as Bill told, so HDKK is something like the hot shot. So we don't need any additional hot shot for HDK. But for Del Nido, within this 300 different formulations, maybe 100 of them gives suggestion for a hot shot at the end of Del Nido.
We have one more question from Paulo Prates. He's congratulating the speakers, and his question is about what would be the best cardioplegia for congenital patients requiring long ischemia time.
Well, I don't do pediatric cardiac surgery, but I believe both may work. Del Nido or HDK are both supportive for pediatric patients.
Well, I will comment that effectively, as Dr. Gunaydin has said, that absolutely, I feel that they are equivalent. The one caution with custodial HTK in the pediatric group is the need to vent the custodial cardioplegia, because a higher volume of the custodial in the pediatric practice can shift the sodium and create some neurological deficits if you're not careful in your practice. So if you vent the custodial for all pediatric cases, absolutely equivalent in that regard.
I have a question from Marco Lima. It still remains doubt about the custodial efficiency for CABG in severe coronary disease. The use routinely is safe. I'd better always use the retrograde access.
Well, I do too. I always use retrograde access. And for single dose techniques, for example, for up to 3 vessel CABG, I always use blood cardioplegia because the cross-clamp time is usually short. For, let's say, 5 CABG plus 5 or more, single dose may be an alternative, but with the retrograde access.
And I'll just add one slight concern that I've seen throughout the United States in my experience with its use in CABG is that if you don't mark your targets well, because you're using straight crystalloid, it can create a slight bleaching effect and make it difficult to track your targets. So if you're going to use it for those type of patients, make sure that you're adequately identifying your targets well before you arrest.
there's one question to Bill. This question was sent by Fernando Hartbart. Could you please talk more about Hammel's paper regarding cost comparison? What were the parameters demonstrated by the author that could measure the final cost per patient instead of only the price of the solution?
Yeah, and I'm going to go off memory instead of re-pulling up the slide. That's a great question. I appreciate that one. So we know that the pharmacy costs at his institution went up by 25% in the pharmacy supplies, as you would expect. But the cost intraoperative for supplies, such as the need for retrograde cannulas, significantly decreased. The cross-clamp times were lower because of the reduced amount of time necessary for reperfusion. So intraoperative costs were significantly reduced. Anesthesia times were factored in there. So what anesthesia charges for their particular time in the operating room, as well as the inotropes that they were using. And then post-operatively, the costs were factored in there as well, the need for inotropes, the length of stay. And so when factoring all of those compared to standard blood cardioplegia technique, that the hospital did in fact show a cost savings of $3,000 per procedure here in the United States when using custodial as compared to blood cardioplegia.
We have one more question here from Juan Cáceres. Has any of the presenters used the Unido solution variants? In adult service, Plasma Light is not available every time, and we choose to use Ringer instead, with similar results as the original formula, but with a little bit more of acidosis in the post-operative.
No,
that's a variation. That's a different thing, isn't it?
Yes, yes. So we always do studies with the conventional formula.
Right. And I've actually was at an institution, speaking of variances, that would use Plegiosol and change its composition, changing the original Plegiosol formulary to create a in-house Del Nido, so a self-made modified Del Nido, and the results produced right heart failure, pulmonary hypertension, and was stopped almost immediately. So the modification was not good when using a base that wasn't intended to be manipulated.
Okay, I think we need to close this session, and if you have any more questions, I think we have covered most of the questions. Very nice questions coming from the audience. Once again, thank you very much to our speakers, especially Dr. Serdar. It's almost breakfast time for him. And yes, and thank you, Bill, for joining us tonight, and Mateus. And we much appreciate the cooperation of Contact Medical for promoting with the Brazilian Society of Cardiovascular Surgery this very important webinar. Very nice and very fruitful discussion.
Thanks a lot.
To you, Eduardo, for final remarks and closing. Thank you.
I'd like to thank you, everyone, to be with us tonight. It was an honor, and I expect to see you soon. I look forward to see you soon, back here in Brazil.
Thank you very much.
Yeah.
Thank you.
Nice night. Thank you.
Thanks, Bill. Thanks, Serdar. It was a pleasure. Thanks for organizers. Thank you.
Good night.
Right.